Good morning, audience in Korea. Good evening, audience in the States. Thank you very much for joining our webinar today. My name is Junho Yoon, and I'm a commercial specialist covering healthcare sector at the commercial section in the U.S. Embassy in Seoul, Korea. It is a great honor to be your moderator today, and I'm happy to meet you virtually at today's webinar. Today's event is co-hosted by AMCHAM-Korea and the commercial section at the U.S. Embassy in Seoul. 3 guest speakers from public and private sector has joined us today, including Seoul National University Bundang Hospital, U.S. healthcare firm Baxter Korea, and law firm Lee & Co. I would like to deliver my sincere gratitude to AMCHAM Korea for the effort and time to co-host this event today, and the speakers who have spared their busy schedule and prepared useful presentations. To highlight today's webinar program, we will go over the market overview of Korea telehealth industry, U.S. telemonitoring companies' business development story in Korea, and finally, prospective regulatory changes and its implication for U.S. companies. We will also have Q&A session towards the end of webinar, so please feel free to type your question in the chat panel during the webinar, and we will work to answer your questions towards the end of the webinar today. Additionally, we will ask simple questions with multiple choices to choose from at the end of each presentation. This is to better understand your needs and would not take so long, so we would appreciate if you could click on any of the multiple choices that fits best to your situation. Now, I would like to first welcome a commercial officer at the U.S. Embassy in Seoul, Artina Davis, for her opening remarks.
Thank you, Junho. Hello, everyone, and welcome to today's telehealth webinar. I echo Junho's sentiments and would like to give a big thank you to AMCHAM for collaborating for today's webinar. And thank you to today's speakers. We here at the commercial section at the U.S. Embassy have had no better partner in helping U.S. businesses expand in Korea than AMCHAM. As the export promotion arm of the U.S. Department of Commerce, we have a network of commercial service offices and embassies and consulates around the world, in addition to domestic offices throughout the U.S., all designed to assist American companies looking to expand in overseas markets. And as part of our Select USA investment initiative, we help companies invest in the U.S. to facilitate foreign direct investment. For today's webinar, we have a diverse lineup of experts that will speak on the various aspects of the telehealth landscape in Korea. We hope you find today's webinar helpful. Thank you.
Thank you, Officer Davis, for the great opening remarks. Now, it is my great pleasure and honor to invite the co-host of today's event, Chairman of AMCHAM Korea, James Kim. Chairman Kim, please share a few words for our participants today.
Good morning. Thank you very much, for the very kind introduction. As always, I want to thank Artina Davis and all the hardworking officers at the U.S. Embassy for what I think they do a fantastic job in really expanding the U.S.-Korea partnership. For me, it's always great to collaborate with our friends from the U.S. Embassy, and I think that today's event is what I call a highly relevant topic for all of us. In fact, I just came back from the U.S. A few nights ago, and I can tell you that many of my friends in the U.S. are already using telehealth for their medical requirements. And it's a fantastic solution for all of my friends who are already benefiting from it. So with that, I'm very thankful for our speakers today. President Baek Nam-jung of the Seoul National University Bundang Hospital, our good friend from Baxter Korea, Donald Hyun, and of course, Eileen Shin from Lee & Co. When I look at today's webinar, the topic is navigating the landscape of telehealth in Korea. And as I kind of talked about briefly, telehealth is such an exciting new frontier for the healthcare industry in an area with so much potential for cooperation between US and Korean companies. And because Korea has one of the world's most effective healthcare systems, as demonstrated by a strong response to COVID-19, I also look at Korea as a pioneer in the digital world, given the fastest internet speed in the world today. But US companies are also world leaders in healthcare innovation as well, along with IT. And I'm so glad that many iconic US healthcare companies are joining the conversation today. Johnson & Johnson, Pfizer, MSD, Viatris, and many, many more. So I'm very excited about today's session. So I want to thank again our friends from the US Embassy, all the speakers, and for the US Embassy for doing this amazing work. So now, without further delay, let me get it back to you, Juno. I'm going to listen in today, and I hope to learn a lot from all of you. Thank you.
Thank you, Chairman Kim, for your speech. Now, I would like to introduce our first webinar topic and speaker. The first presentation topic is the market overview of Korea telehealth industry. It will be given by the President and CEO of Seoul National University Bundang Hospital, Medical and PhD Dr. Nam Jong-baek. Dr. Baek received his MD from Seoul National University and PhD in Preventive Medicine from Seoul National University. He held numerous positions, which include Chief Public Health Officer, Chief Finance and Strategic Officer, Chief Communications Officer, the Director of the Referral Center, and the Department Chair. Among several positions he has now, he is the President and CEO of Seoul National University Bundang Hospital, and also a Board of Director for the Korean Telemedicine Society. President CEO Baek, please show up. Thank you.
So it's a pleasure to meet you via Zoom. As many of you know, Korea's medicine has close tie to the US. Many members of AMCHAM are from biomedical industry. COVID-19 has and is and will change medicine in a fundamental way, which brings us the subject of my presentation, telehealth in South Korea. I hope my presentation can be a good entry point to understand the changes taking place in Korea. Okay, as you can see, I have prepared 6 points. I'll begin with the definition and market situation of telehealth and telemedicine. Then I'll explain about the deployment history and current status of telemedicine in South Korea. Next, I'll be looking at the challenges Korea faces in implementing telemedicine and the strategies to overcoming them by the Korean government. Lastly, I'll share our experience and plans in telehealth and end with the lessons we've learned and future directions. What is telehealth? According to a study, telehealth is a part of e-health, mainly standalone health management service type products, handling patient-generated health data in a consumer-driven market, while telemedicine focuses on integrating data from hospital-centered platform and patient-centered platforms in a hospital-driven market, providing curative health care to those requiring or seeking professional treatment within the telehealth field. The global telehealth market size is US $44 billion in 2019, according to the Fortune Business Insight. COVID-19 triggered a demand shock not only in the US, but across the world, and telehealth service use is projected to grow at a constant rate. Telemedicine market continues to grow in Europe and Asia. Within Korea, the market has not been established yet. Korea began its telemedicine journey in 1998. The remote image diagnostic project was the first pilot project of Korea. In 2002, thanks to the amendment in the Medical Act, telemedicine between licensed medical professionals was legally permitted for the first time. In 2006, the first patient-physician telehealth pilot project took place, but it never made to the next stage. Since then, there were many pilots, but never a full-scale operation. COVID-19 changed the dynamic of healthcare delivery, and the Korean government temporarily legalizes telehealth between patients and physicians. The Korea groups telemedicine service into three major parts. First is what we call teleconsulting, which is consulting of a patient case between two physicians. Second is telemonitoring, where a physician monitors patient remotely. Last is the teleclinic, where a physician provides consultation services and treatment to a patient in a remote location. Under Korean medical law, teleconsulting is the only legal form of service, while telemonitoring and teleclinic are illegal yet. In a survey asking 1,000 medical service users, 82% of the respondents replied that they are willing to use telemedicine service. 94% of respondents replied that they will use telemedicine service from their second visit. Respondents were most concerned about malpractice and medical accidents. Other factors that made users wary of telemedicine were expensive devices and poor quality of medical service and risk of data leak. It's evident that consumers are ready to try telemedicine. However, we still have many hurdles for telemedicine to become a mainstay delivery form of healthcare in Korea. First is the tight regulatory framework around telemedicine. Second is the lack of reimbursement or financial model for healthcare providers to create ROI. Third, if we do legalize telemedicine, there is no robust evaluation models on the outcomes of telemedicine. Lastly, many patients worry that healthcare delivery system of Korea might be collapsed, and if we hastily adopt telemedicine, it may exacerbate the concentration to the tertiary hospital, which is already a problem in Korea. Understandably, these concerns make it difficult for Korea to actively embrace telemedicine. Interest groups all have their own take in telemedicine. The Korean Medical Association is a stanch critic of telemedicine, citing the crumbling healthcare delivery system and increase in medical costs. The Korean Hospital Association does not right out oppose telemedicine, but is cautious about implementation, saying that the safety and efficacy of telemedicine must be verified first. The Korean Institute of Medicine is highly concerned that telemedicine will widen the medical divide between urban and rural medicine. The Korean Nurse Association is pushing for their interest, saying that telemedicine should be legalized between medical staff and community care nurse. The Korean Pharmaceutical Association is against telemedicine, saying that it will only increase healthcare costs and medical accidents. The conflicting interest among interest groups made it extremely difficult to adopt telemedicine in Korea. The government started a regulatory sandbox for telemedicine, allowing services to overseas Koreans as a way to test the effectiveness and safety of telemedicine. After COVID-19, teleconsultation, including prescribing medicine and prescription refill by authorized caregiver, were temporarily permitted. The outcome of COVID-19 regulation lift seems successful. As of May 10th of this year, over 3,000 hospitals participated in telemedicine and prescription program, prescribing over 16 million prescriptions with the 86% patient satisfaction rate. Now let me share our experience and future plan. Technically speaking, the technologies needed to implement telemedicine are nothing new. Since opening in 2003, our hospital developed an EMR system and had been using it hospital-wide. We have been continuously developing our hospital information system along with various health IT that can be utilized in telemedicine. To name a few, we have developed an electronic rapid response system for patient monitoring, an electronic survey system to collect patient-generated health data, and a patient health record system. Thanks to these technologies, which was a spontaneous effort of SNUBH, we were able to stay ahead of a curve and quickly design and implement a telemedicine platform amid the COVID-19 epidemic, minimizing disruption. Not to mention lessening the burden of our medical staff. Since COVID-19 hit, SNUBH is running a remote consultation and prescription delivery system. Appointment booking, consultation, payment, prescription are all done remotely. Physicians do not need to open a separate program for telemedicine. They can select a patient from the EMR program that they use for everyday practice and hold a teleconsultation session, prescribe medicine the same way they would do for a regular in-person patient. The prescription will be sent electronically to the patient. As for the patient, they won't need to download or set up a different program for the telemedicine consultation or prescription. Next, let me talk about how we used our telemedicine platform to care for discharged patients. Our rehab department manages patient discharge to a local rehab hospital after receiving acute care in our hospital using telerehabilitation. Local doctors can consult with our doctors on patient cases and contribute to strengthening the continuum of care through telemedicine. SNUBH developed and implemented the tele-ICU e-ICU platform for telemedicine among medical staff. Using this platform, medical staff in the ICU can remotely consult with medical staff in other locations of a hospital or even outside the hospital. We also provide medical opinion and consultation to secondary hospitals who may be short on ICU staff or lack experts in certain fields. This has been a great relief on the enormous burden ICU staff had to face during the height of COVID-19. The map on the left shows the total number of ICU beds, the available number of ICU beds, and isolation beds in the region. The screen in the middle shows the available medical resources of each hospital participating in the e-ICU program. Using this platform, we are playing a key role in managing the limited ICU resources available in the region. The e-ICU is designed to support the care of critical patients, allowing medical staff to effectively assess the ICU patient remotely and take stock of the available ICU resources in real time. We have successfully operated a community treatment center during the height of the COVID-19, utilizing the various health IT resources we have developed so far. In the community treatment center, we managed COVID-19 patients with mild symptoms using telemedicine platform. Since 2003, SNUBH is operating a homegrown PHL system. Patients can review their medical record and manage their prescription using the PHL. Also, they can download their medical history using the blue button function. Since 2017, we have been integrating patient-generated health data collected from Apple Health and Samsung S Health into Health for You, which is our hospital's PHL apps, and is then integrated into our main EMR. Patient-generated health data has great potential when used in a meaningful way. Integrated into our hospital-generated data, patient-generated health data can be utilized in a population health management through big data analysis, offering preventive health management service based on patient risk factors. Telemedicine solution can be used to manage post-discharge care for patients that have undergone surgery or ICU care. Emergency patients can receive acute care through our eICU and telemedicine system. SNUBH can serve as a regional healthcare management hub by integrating population health management and telemedicine, providing technical support such as telemedicine and population health management solutions for chronic disease management, and identifying patients at risk and notifying them to local clinics and treating them when they require tertiary care. There are three key lessons from Korea's telemedicine journey. First, there has to be a consensus among civil society, healthcare professionals, and various interest groups to adopt telemedicine. Difficult concessions need to be made, and a social consensus has to be reached. Second, the government must have a strong determination to implement telemedicine. Lastly, healthcare providers must be technically prepared to adopt telemedicine. To this day, Korea's telemedicine market is lackluster. However, COVID-19 has unleashed consumer demand to provide everything and anything online, and medicine is no longer exception. Within the next 3 years, I believe we'll see an influx of telemedicine-related technology and products in our market. Korea is not the biggest market in Asia in medicine, but we are sure one of the most credible, trusted, which is very important in medicine and Asia. I hope my presentation was able to shed some light into the Korea's doing and what SNUBH is doing as Korea's undisputed leader in healthcare IT. Thank you for your attention.
Thank you, President CEO Baek, for the informative presentation provided. It was very helpful to understand the overall telehealth system in Korea and what we can expect to happen in the Korean telehealth market in the near future. I would like to turn to the second phase of our webinar. The next topic is regarding U.S. telemonitoring companies' business development story in Korea, and it will be presented by the General Manager of Baxter Korea, Donald Hyun. Donald is in his second tenure as GM of Baxter Korea. Prior to rejoining Baxter, he was the global brand leader for adolescent vaccines since 2016. He was the managing director of MSD Korea since 2008. Prior to joining MSD, Don was the general manager of Baxter Korea from August 2004 and held various positions over 19 years in the healthcare industry throughout Asia. Donald will talk about the U.S. telemonitoring company's business development story in Korea. General Manager Hyun, please show up. Thank you.
Thank you very much for the nice introduction. It's a pleasure to be here, and certainly thank you to all our friends at AmCham for this opportunity. CEO Baek Nam-jung mentioned a very important challenge for the entry of telemedicine in Korea. I think it's not unique to just Korea, but I guess in most countries around the world. There are conflicting groups. Special interest groups can be applied to the term, but the regulations to satisfy all of these different groups within the ecosystem is a huge challenge. So that's something the industry, government, and medical societies really need to work together to overcome, because telehealth, telemedicine will be beneficial for government, for citizens, and healthcare professionals. And maybe what I'm going to talk about today is kind of an entry step into that transformation. There's that phrase, one has to learn how to walk before they run. And I'm going to talk about peritoneal dialysis and a technology that we have, Sharesource platform, that impacts in a positive way a certain group of dialysis patients. Okay, before I do that, I would be remiss if I didn't take a moment to introduce our company, Baxter. Our mission, saving and sustaining lives. Baxter globally has been doing that for 90 years. In Korea, it's our 30th year, and I really look forward to celebrating our 30th anniversary later this fall. I wish we could do it in person, and perhaps we will be able to do it partially, but most certainly we'll get everybody online. Some of the innovative products that Baxter has produced and launched globally, I'll speak about two of them. You see the infant here, and when I see that infant, the product that immediately comes to my mind is Numeta. Numeta is a pre-mixed solution where physicians can add on extra medicine and solutions depending on the preterm baby's condition. Now, currently in Korea, for preterm babies, the solution is made from the pharmacy of the hospital from scratch. So that takes a lot of time, but in the process, there are risks of infection and contamination. So having a premixed solution in Numeta significantly is able to reduce that type of risk of infection. The next product I'd like to talk about is Theranova. It's a dialyzer which is used as a filter for hemodialysis patients. In particular, hemodialysis patients that have been on therapy for a long time, this product is of a special benefit to them. So I always say that, you know, the basics of digital transformation has been around for quite some time, especially in the healthcare industry. But even not related to healthcare, just FaceTime or, you know, things like Zoom and so forth have been around quite a while. It's just that we never thought to use it because face-to-face interaction was always preferred and it was always more effective. But the transition to digital was always going to happen. But the pandemic has accelerated that transition exponentially. And that certainly is true for us at Baxter. So one of the transformational and innovative digital technology that we've been able to introduce is called Sharesource platform. Before I talk about Sharesource more, allow me to introduce the therapy platform that Sharesource belongs to. And most people know about hemodialysis, but there's also another form of dialysis called peritoneal dialysis, or PD. And traditional PD is done at the patient's home, and it requires 4 solution exchanges throughout the day. And each exchange takes about half hour to 45 minutes, depending on the fluency of the patient. It's done independently at the patient's home or workplace, depending on the patient's situation. But you can see that, especially if a patient is working, having to take a break 4 times out of the day is quite cumbersome, although many people do it. Now, there's another form of PD that's called APD, automatic peritoneal dialysis. And what you see here in this picture, you see we call this the cycler. That's the APD cycler, the monitor that helps with the fluid going in and out of the peritoneum of the patient. And you can see that they're getting ready for bed. So the beauty of APD is it combines all the 4 exchanges into one, and the exchange can be done while the patient is sleeping. So this not only provides a tremendous benefit in terms of quality of life, but for the workforce, obviously it's a tremendous benefit because you don't have to take half-hour, 45-minute breaks throughout the day. How Sharesource works, it's very simple. You saw the cycler that was next to the bed at home, and through the information, the results of the dialysis is sent to a cloud, and within that cloud, there's two-way communication to 2 points. First, the hospital, real-time dialysis results and other vital signs that go to the healthcare professional, and then how the cycler performs. Does it need repair? Is something going wrong? Our engineers can get that information real time and put immediate fixes on it, so there's no inconvenience to deliver life-saving therapy to patients. The beauty of this is that in traditional CAPD or traditional PD with the 4 exchanges, the results of the dialysis had traditionally been written on hand note by the patient. And then since outpatient is usually only once a month, the healthcare service provider or doctor doesn't see the results, whether it's good or bad, until about a month later. Now, of course, if the patient is feeling bad, then the patient goes in. But with Sharesource, before the patient feels bad, the healthcare professionals are able to see real time if something is going wrong. So prevention, that the dialysis results, the metrics aren't going right versus protocol. Then what happens is that the PD nurse or doctor will call the patient before they start feeling bad and ask them to come into the hospital. And then they can change the prescription, change the dynamics of the peritoneal dialysis settings, and so forth. So this is a tremendous benefit. PD patients are considered handicap class 2. And so this is a very niche set of patients needing this therapy, and clearly providing value both to the HCPs as well as the patients. So when I say, one needs to learn how to walk before one starts to run, I think this is a very good example of how we can take these steps entering telemedicine and also telecare between patient and the hospital. All right, so I think I've touched up on most of these, but I'd like to say that telemedicine and the therapies that are being developed are here to stay. I think as industry leaders, as healthcare professional leaders, and for the benefit of the patients, it is our responsibility to work with government to form the right regulations that is balanced and is benefiting all groups. I truly believe that there is a way to do that. It's just we need to take the first steps and then move forward step by step. One experience that I had was back in 2018 when there was a GM vacancy in Baxter, Japan. In the interim, I had spent some time there helping out Baxter, Japan, and I met an old friend who's a journalist for one of the major dailies here in Korea. And he was on sabbatical there for some time. And it was interesting because The reason he was there was to observe how the Japanese government manages the lack of workforce and in an aging environment or aging society. Korea is certainly one of the fastest aging societies in the globe, and it's something that we need to solve for going forward. APD with Sharesource therapy is a great way to help the workforce or help even an aging society be able to continue in the workforce as needed by the government and just the general economy. And as CEO Beck mentioned, we must work out good policies, fair reimbursement policies for these therapies, for these services, and then fuel the R&D pipeline for more to come. And I'd like to end by introducing, there's nothing more powerful than a patient or a healthcare provider testimonial. So nurse, head PD nurse from Seoul National University Hospital, and we are currently in a shared decision-making pilot program phase with the government and partnership with the Korea Society of Nephrology. It's been about 18 months, and Nurse Kim is, very grateful and complimentary about how Sharesource has been able to improve not only patient outcomes, but also convenience of care and the ability to provide higher quality care from HCPs to patients. Thank you for your attention.
Thank you, Donald Hyun, for the informative presentation provided. I think this presentation helped us understand how the telehealth in the private sector is actually working in the global stage and what we can expect to happen in Korea. So last but not the least, I would like to introduce our last webinar topic. Senior Foreign Attorney Jae-young Shin from Lee & Co. will give us the presentation on prospective regulatory changes and its implication for U.S. companies. Shin is a member of the Healthcare and Life Sciences Practice Group, specializing in the areas of general corporate matters, commercial transactions, and healthcare industry regulatory compliance. She has extensive experience in advising clients in the pharmaceutical, medical device, cosmetic, tobacco, and food industries on regulatory compliance and corporate transactional matters. In addition, Ms. Shin regularly advises multinational clients on new drug pricing and after-launch lifecycle management with the firm's active market access team. Shin's presentation will discuss prospective regulatory changes and its implication for U.S. companies. Senior Foreign Attorney Shin, please show up. Thank you.
Hello, nice to meet everyone, and thank you so much for having us here. I'm also joined here with Ji-Yeon. She's a partner in our healthcare team, healthcare practice, and she will stay on until the end of the presentation to assist me in answering questions, or if I miss anything, she'll join in and help me out. So in today's presentation, I will briefly go through the current regulatory environment for telemedicine, some exceptions from these restrictions, both statutory and non-statutory, and then briefly discuss expectations going forward. So first, beginning with the regulations. So simply speaking, telemedicine in Korea from a regulatory perspective is prohibited. And this prohibition comes from Article 33 of the Medical Services Act, which provides that if a medical personnel can only cannot provide medical services unless he or she establishes a medical institution and the medical service is provided in that medical institution. So taking this language, the court and the authorities have been interpreting this to prohibit telemedicine in Korea. One major change to the regulations occurred in 2002, which is about 20 years ago, where the Article 34 of the Medical Service Act was included. And in that article, it says, notwithstanding Article 33, medical personnel may provide telemedicine services to other medical personnel, which means that doctor-to-doctor telemedicine is allowed in Korea. And what that means is doctor-to-doctor telehealth consultation. So consultation among doctors from different institutions via telehealth communication technology, that's allowed, or via telephone. However, doctor-to-patient telemedicine is strictly prohibited in Korea. And one recent exception that has been made, it's not a statutory exception, but it's more of an interpretation exception. The Ministry of Health and Welfare has taken the view recently that telemonitoring is not telemedicine, so it is permitted. So the MSA prohibition on telemedicine does not prohibit telemonitoring of patients by doctors. And what that means is the doctor is able to remotely monitor the patient's health or condition, and then provide relevant consultation. However, that the scope of that consultation is also open to debate. What we know for sure right now, based on a recent administrative opinion that was issued by the NYHW, is it involved a EKG wearable watch type device where a doctor is able to monitor the patient's heart rate remotely. And then if he or she sees any issues, then the doctor can request the patient to come in for consultation, face-to-face consultation. With that specific service alone, the MHW was of the position that is not prohibited by the Medical Service Act. So what we know now is that telemonitoring is okay. However, relevant consultation, it depends. We know that it cannot rise to the level of medical treatment or diagnosis. But if it's limited to requesting the patient to come in, that's allowed, we know that. Whether it allows a consultation that does not rise to the level of treatment or diagnosis, but nevertheless still doctor consultation, that seems to be okay, but it should be reviewed on a case-by-case basis. So in conclusion, doctor-to-doctor telemedicine is okay. Doctor-to-patient telemedicine, not okay, but doctor-to-patient telemonitoring is okay. And the thing with doctor-to-doctor telemedicine is it's been permitted under the law since 2002. However, we haven't seen much activity with it in the medical community. So in recent years, the government has been trying to promote this area. So I think 2017, last year, the National Health Insurance Reimbursement Act was amended to provide national health care coverage for teleconsultations among or between doctors. But even so, it does not seem like there's much active use in that area. We have one small statutory exception to the prohibition on telemedicine, which was included last December. It was an amendment to the Infectious Disease Control and Prevention Act, IDCPA, and it's been amended to allow telemedicine in certain crisis situations arising due to infectious disease. So if the social alert level rises to serious or above, then the government, then we now have legal basis under the IDCPA where telemedicine will be allowed temporarily. But this is only a small statutory exception, and by making this change, no change was made to the Medical Service Act. So that still remains as a prohibition. Next, in the next few slides, I'm going to discuss some non-statutory exceptions to the restrictions that's been recently going on. The first is with the continuation of the COVID-19 crisis, the MOH, and this is even before the amendment to the IDCPA. So before that amendment came about, when the crisis was first beginning to become serious in February of 2020, The MOHW issued an administrative order, and CEO Peck briefly explained this in his presentation as well. The MOHW issued an administrative order which allowed telemedicine until the COVID-19 crisis endures. And so telemedicine is allowed, teletreatment, telediagnosis is allowed, drug delivery is also allowed, and telemedicine treatment is also covered by national insurance. And in fact, the coverage rate is higher than normal face-to-face outpatient services. So we're not seeing, I think the general public, although being very aware and also gaining a common understanding of the need for telemedicine, because the general public is not so used to non-face-to-face consultations with doctors, it's not as actively being used, but still we're accumulating a lot of good clinical data that will that we're sure will provide a good basis for how telemedicine regulations should develop in the future. So we're accumulating a lot of good safety and efficacy data through this temporary measure. Another area of non-regulatory exceptions to telemedicine prohibition would be some pilot programs run by the government and Sandbox experiments. So despite strong opposition from various medical community interest groups, the government has always been trying to explore this area of telemedicine. And since about 20 years ago, the government has been running a pilot program that allows telemedicine for rural areas, mountainous and island areas. And that's been going on for a very long time now, almost 20 years. And then in recent years, the government has also implemented per disease type pilot programs. For example, for diabetes patients and PD patients. So these programs are provided by pre-specified medical institutions that have signed up to provide the services. And it involves patient management, home care patient management, which involves remote monitoring of the patient's health status and also providing remote relevant consultation. And these services are also reimbursed under the national health insurance. So other than these two that's indicated in this chart, we have a total of 5 home care pilot programs that are currently ongoing by the government. And then we also have a few regulatory sandbox programs that are being implemented currently. The first regulatory sandbox experiment that relates to telemedicine involves a watch type ECG monitoring device, which I briefly alluded to in my explanation of the MOHW opinion, administrative opinion on remote monitoring. So what's interesting about this is, so remote monitoring is okay. And in order to stay away from the teleconsultation that may encroach into the area of teletreatment or telediagnosis, the app provides 2 separate displays for the patient and the doctor. And so for the app display for the patient, it would show the health status of the patient and likelihood based on publicly available scientific data. However, for the doctor's web viewer page, the doctor can remotely monitor the patient's condition and input his or her diagnosis of the patient for future treatment reference purposes. However, that diagnosis would not be transmitted to the patient because that would go into the area of telediagnosis, which is not allowed under current interpretations of the law. So we have many regulatory sandboxes that are ongoing right now. About 33 relate to 8% out of the 410 that's currently ongoing relate to medical service. And regarding telemedicine, we have three sandbox programs that are currently ongoing, which involves the ECG monitoring device that I described, telemedicine to Korean overseas, and telemonitoring service for hypertensive patients. So expectations going forward. So as I briefly discussed, for quite some time, the government has been trying to expand the area of telemedicine despite strong opposition. And not only are we seeing movement from the central government through various programs such as the pilot programs and the regulatory sandbox, we're also seeing some movement from local governments. So for example, Busan has announced that they plan to launch a smart city pilot project in their regulatory free zone, which would offer telemedicine services to its residents. Gyeonggi province also announces plans to introduce telemedicine service in its public institutions, medical institutions. Both these programs have only been announced and they're not in its implementation stage. However, we are seeing that even local governments are realizing that this movement is inevitable, and they're making plans to accommodate this this movement. So despite these changes that have been recently happening, the Medical Service Act still remains unchanged. But as the previous speakers have also discussed, this, especially with the COVID pandemic, what the COVID pandemic has highlighted, this movement towards telemedicine, telediagnosis, teletreatment is pretty much unavoidable. It's a movement that's certain. And also because of the recent technological advancement that's been made in wearable devices, telecommunications, and AI technology, also in developments in digital therapeutics that's already approved, I think one case in the US. All of these technological changes evidence a certain move towards allowing deregulation of telemedicine. Whether it would happen all at once, most likely not, but it seems very sure that changes will happen in increments. And by reviewing the government pilot programs that have been ongoing, we can expect that likely deregulation would occur on a per disease basis, particular diseases where the efficacy and safety risks of telemedicine provision has been already shown, and most likely through the COVID-19 crisis temporary allowance, as well as the pilot programs. We expect that in those areas, we would see limited and incremental deregulation. And also, not only is deregulation important, we also need to develop a criteria or a set of standards that would allow reimbursement of these telemedicine services. And that's also something that should simultaneously grow together with deregulation to make these changes practically useful and meaningful. So that is the end of my presentation. Thank you.
Thank you, Senior Foreign Attorney Shin, for the informative presentation provided. If anyone has a question now, please type in your question at the chatting panel now. I think this should be the end of our webinar today. Thank you, audience in Korea and the States, for joining us today. I appreciate for AMCHAM Korea to co-host today's event, and 3 guest speakers who have spared busy schedule and delivered precious information today. I hope to meet you at the next webinar program again. Thank you and goodbye.